Well, I want to welcome everybody today to the Impact Education program. And this is one in their series that they call Payer Talks, which is a CE program that's going to highlight understanding type 2 inflammation, best practices in EoE management. I'm Dana McCormick. I'm a senior director with Optum Insight, which is a data analytics and actuarial practice within Optum. And we do a lot of work with organizations on pharmacy strategy, just kind of in general. I'm super glad to be here with you all. The activity today is supported by an independent educational grant from Regeneron and Sanofi, and we'd like to thank them for their support in making this program available. It is also jointly provided by the Partners for Advancing Clinical Education and Impact Education LLC. At the end of the program, you'll be able to complete an evaluation, which will need to be submitted in order to obtain the credit. You'll just click on the complete evaluation in the navigation within the activity. And once you complete the evaluation, you can click on Claim Credit to download your certificate, or for pharmacists, submit your credit to the CPE monitor. And I am so excited today to be joined by Dr. Dellon and Dr. Drake Reiter. Dr. Dellon is an academic gastroenterologist who has formal research training in epidemiology, clinical and translational research, and clinical trial design. He leads and collaborates with a multidisciplinary research team and focuses on esophageal diseases, just in general, and then also in the area of eosinophilic esophagitis in particular. Dr. Reiter is a pharmacist and is the director of pharmacy operations at Priority Health. I want to welcome you both. Dr. Reiter, you want to introduce yourself real quick? Give everybody a little bit about your background.
Yes, thank you very much, Dana. Hello, everyone. Happy to be here. As Dana mentioned, my name is Drake Reiter. I currently serve as director of pharmacy operations at Priority Health. In my current role, I kind of have two primary areas of responsibility, one being over PBM and operations with the PBM, and the other is around clinical innovation and program innovation in general. So responsibility over a large variety of topics, including clinical program development. My background, I am a pharmacist. I have worked for another health plan, mid-sized Blues plan located in the Midwest, where I worked as a clinical pharmacist, doing a lot around formulary utilization management, also a little bit of policy work and other things in that role. And I also served as executive fellow for the Academy of Managed Care Pharmacy, or AMCP, where I developed just broad expertise in the field of managed care and some of the innovative topics in there. So very much looking forward to the discussion today. And thanks, Dana, for the opportunity to introduce myself.
All right, Dr. Dellon.
Yes, hi everyone. I'm Dellon. It's great to be here. I'm a adult gastroenterologist at University of North Carolina School of Medicine in Chapel Hill. I direct our Center for Esophageal Diseases and Swallowing here. And in general, my practice is really focused on patients with eosinophilic esophagitis, or EoE, and other eosinophilic GI diseases, or EGIDs. I spend a lot of my time also doing research across the field in epidemiology and outcomes, and a lot of clinical trial work these days. So it's great to be here, and I really enjoy these multidisciplinary discussions.
Today's learning objectives is to assess payer care management initiatives and other opportunities to improve treatment access and overall quality of care based on current evidence from clinical trials and treatment guidelines. So, Dr. Dellon, let me start with you. We'll jump in with a question here. So, can you talk a little bit about the current treatment guidelines for managing EoE, and how do you feel like these guidelines assist clinicians determine appropriate treatment strategies for the different patient populations that suffer with EoE?
Yeah, thanks, Dana. So we're in a really good place, I think, in the EoE field. Things have matured a lot over the last 10 to 15 years in terms of the evidence base that supports our treatment. And finally, up to now having in the US 2 different medications approved in 2 different drug classes for EoE. So we have diagnostic and treatment guidelines. We actually have best practices for endoscopy guidelines. We have monitoring guidelines. And we also have a new tool that helps us define severity in EoE. And so we have a lot of tools available. The most recent ones that were published were from 2020 in the American Gastroenterological Association. But as we talk now, we are awaiting publication of brand new guidelines from the American College of Gastroenterology, which really will update some of the management algorithms and make some new recommendations. There are other guidelines from around the world, like there are European Pediatric Society guidelines, there's British Society guidelines, there's Italian Society guidelines. So there are a lot of ways that we look to try to standardize practice. In general, the goals of treatment that the guidelines try to recognize are to improve patients' experience with EoE across several domains. So we're looking at symptoms and, of course, hoping that people feel better. But symptoms aren't the only thing, because they don't always respond or act in concordance with the biologic features of the disease. And so we also like to look at endoscopic and histologic improvements as well. So how does it look when I get the scope down there? How does the lining of the esophagus look? Is it healing? And then on biopsies, are we seeing improvements in inflammation? And this is not unique to EoE. If you look in the field with inflammatory bowel disease, it's perfectly possible that someone with Crohn's disease feels very well, but their bowel is still very inflamed and angry, or vice versa. They may have ongoing symptoms, but their bowel looks quite well. And so you have to sort out what's going on with those individual patients. So we look to those domains. We also want to prevent future complications. And of course, in children with the condition, we want to make sure that they have normal growth and development and nutrition. When we think about treatments in general, all of the guidelines are pretty consistent in suggesting first-line treatments in different categories. And the main deciding factor is whether patients really want to pursue diet elimination or a medication. And the deal with diet elimination is that we think for most people, EoE is a food allergy-driven condition, but it's not an immediate food allergy. And we don't actually have allergy tests to tell us what food is the trigger, or what food or foods are the triggers for EoE. And so those are empiric elimination diets. And that's really a patient choice, whether they want to go down that route and pursue the diet elimination. It can be a very time and resource intensive process. And so that's really the first distinction. But, then from the standpoint of what we're talking about today in terms of pharmacologic agents, the main first-line agents are proton pump inhibitors and topical steroids. And interestingly, most of our evidence, and these are recommended in guidelines, and most of our evidence base on PPIs are from observational studies. We don't have any placebo-controlled trials of PPI use for EoE. And of course, they're used off-label. They do have a different mechanism in EoE than the anti-inflammatory mechanism. They appear to block one of the allergic cytokines that draws eosinophils into the esophagus. And so it is a unique mechanism, but you need a higher dose, usually twice daily or double daily dosing than what would be approved for reflux. And that's one thing that sometimes gets into dosing and insurance issues. The other type of medication are topical steroids. And for several decades before we had anything approved, patients essentially adapted asthma medicines to swallow rather than inhale and coat the esophagus with an anti-inflammatory steroid that did a nice job taking care of the eosinophils, but was very frustrating because it was off-label and you really never knew what the patient was getting because they were modifying these medications themselves. But finally, just this year, we had a topical steroid, budesonide oral suspension approved, FDA approved in the US in the context of another topical steroid, a dissolvable tablet of budesonide being approved in Europe and around the world since 2018. And this medicine also is pretty effective and it's specifically formulated for EoE. Then most of the guidelines would say, if you don't respond to one of those treatments, then you might step up to a more advanced treatment like a biologic, and dupilumab is the other approved medication for EoE. Now, in that situation, however, there are some times that you might consider using a biologic earlier, like if a patient has multiple allergic comorbidities, all of which could be treated with dupilumab, and you could get rid of 3 or 4 different steroid medications, or perhaps if someone is very severe and having a lot of upfront complications. And so there's a little bit of wiggle room like that in the guidelines. And so we try to individualize the treatments overall in the context of the guidelines by patient preference and by the clinical features of the patients.
Thanks for that, Dr. Dellon. Dr. Reiter, can you talk a little bit about, from the payer's perspective, what is the value of clinical guidelines in general, and then specifically as it relates to using them in clinical program development relating to EoE? Kind of how do you think about guidelines in terms of supporting your overall goals of optimizing both clinical and economic outcomes for patients and for your clients?
Yeah, thank you for the questions, Dana. And I'll just preface this too briefly by just outlining how I utilize clinical guidelines in my role today. So, I mentioned I do a lot around clinical program development. I sit as a non-voting member on our P&T committee, so I'm not necessarily a formulary decision maker in my role. However, I'm obviously very plugged into that process and utilizing the outcomes of that process in the clinical programs and working closely with our clinical pharmacists who are helping to develop our formulary and utilization management programs. So I just wanted to briefly set the stage with that too, to provide some context for everyone. To answer your question, I would say guidelines are critically important. And this also, ties into my previous experience when doing formulary management and utilization management activities. They provide significant value to payers. I would say, in general, in the management of any disease state. I know when I was in a role where I was making formulary decisions, guidelines were always one of the top resources that were utilized. Obviously, when a drug gets approved, especially if it's a new therapy expanded indication, FDA labeling is really critically important. In addition to that, if there's any clinical studies that were used to support that approval, those get looked at quite frequently. Really, in addition to that, if clinical guidelines are available from a, sort of a reputable institution that is known in helping to manage that particular disease state, those are used very frequently when helping to, design formulary, create prior authorization criteria, all of those things that typically occur within that process. In EoE specifically, I've been fortunate enough to learn more about this disease state. Up until about a year ago, I'd say I had very little knowledge of it. And I would say that probably a lot of clinical pharmacists who are in similar roles would say the same thing. And so I think that this would be leaned upon being guidelines particularly heavily when thinking about how do we build our formulary, how do we design prior authorization criteria, all that sort of thing. So I would say, just to provide a little snippet to how important those are in terms of how we use them to support our overall goals. You mentioned optimizing clinical economic outcomes for patients. I would say that in addition to providing a framework for prior authorization criteria, they also help provide just a general framework for EoE management. So as Dr. Dellon was kind of walking through those, you kind of see the different decision trees or things that need to occur when you're individualizing therapy. So whether a patient decides to use, the elimination diet versus drug therapy, and how that influences the programs that we design. Do we want to offer some sort of food as medicine program or develop one of those in addition to a care management program or something else that we are doing? So we really try to use those to, I guess, reemphasize how guidelines are being deployed in the real world and how providers are using those, because I think our goal is also to encourage optimal outcomes for our patients and our members. And so, that's one way that we try and use those to really optimize outcomes there. I'll also say another thing, it's difficult from a payer perspective too, when there's great variability in care. I think that it makes it difficult for us to, understand some of the real world evidence that is being generated when you have variability in care. So I think guidelines help reduce some of that, provide some predictability. I also think providers are obviously very busy. They're seeing a lot of patients. And for folks like Dr. Dellon, who are experts in their respective areas, we're not trying to create, more barriers to them being able to do their job and to treat patients the way that they need to. And so I think reducing that also kind of helps open up some of that collaboration with providers. And again, just improves overall outcomes. So we're trying to reduce that friction as much as possible. The other thing is, I think when there are, guidelines that are available, say if you're working with provider groups who maybe aren't at a center of excellence or don't treat EoE on a regular basis, I think it provides, a nice way of being able to communicate with those providers of, what type of evidence we're looking for, what are we using when we're building our programs and designing our prior authorization criteria. So again, it maybe helps eliminate some of that friction, and also, just set some of that expectation around evidence that we're hoping to see and different things like that.
Dr. Dellon, could you talk a little bit about approaches to using combination therapy?
Yeah, in general, the guidelines would say wait on combination therapy until after you try individual agents by themselves. From my standpoint, if I give a patient, say, a topical steroid and a PPI, and I ask them to avoid dairy all up front, and they respond, that's great for the patient. But for me, then I have to go through this process of peeling off therapies to try to see, which one of those is actually the effective one, or do they really need that combination? I think it makes a lot more sense, especially, EoE is general. It's not life-threatening. It's usually a chronic onset with symptoms. There's time really to try one therapy, see if it works, keep things as efficient. And then if someone's not responding and they want to or partially responding, then they could maybe add on and layer on another treatment. I think in practice, though, combination therapy is used quite a bit, but there's actually not that much data to support the use of combination therapy.
Dr. Reiter, you mentioned that up until about a year ago, you weren't super knowledgeable about EoE, and that I totally agree with you. A lot of times, as managed care pharmacists are dealing with large populations of people, a lot of times they get focused on the conditions that have high cost drugs, or areas that have management opportunities to drive cost efficiencies and improve outcomes. Do you think that do you feel like there's a good understanding of the role that type 2 inflammation plays in the process of EoE behind the scenes?
When I think about my day today and understanding the nuances between type 1 and type 2 inflammation, it takes me a minute. I may have to go back and reference some clinical literature to really understand what the differences between those are, and especially in EoE, which is a disease state that a lot of managed care pharmacists probably don't encounter on a routine basis. I would say that the understanding there is probably low.
Dr. Dellon, how do you feel like the knowledge and understanding of type 2 inflammation impacts clinician thoughts about treating disease like EoE?
Well, I think for clinicians, they want to understand the cause and the pathogenesis of the disease. So from that standpoint, it's very helpful. It's also helpful to understand where the drug targets are, why they're selected, where they're going to, what the new drug targets are. And so I think as people become more familiar with the disease and with new treatments, they'll understand that a little bit better. I think the other thing we're going to see with EoE is the epidemiology continues to shift a lot, and it's becoming much more common. There's going to be new estimates that are published to show, we usually quote it's like 1 in 2,000 in a rare disease, and that's just not the case anymore. New estimates may show that it's up to 1 in 700 or more, and with more than 500,000 people in the country or more with it, with a large potentially undiagnosed population as well. And so I think having that out there, in addition to, having approved drugs, I think up until 2 years ago, everything we did was off label. And so there was no reason really for any pharmacy benefit managers to know about this, because there was nothing there. And it was always an issue with trying to get off-label asthma medications, essentially. But now I think it's quite different. There's more drugs in the pipeline. There's multiple clinical trials underway. Some of them, targeting type 2 inflammation. Some of them, addressing other mechanisms of the disease. And, as this comes down, I would hope there would be more knowledge, both among providers and among the pharmacy plans as well.
Thanks for that. So when we have innovation in a disease state, like what's happened with EoE in regards to drugs becoming available, a lot of times, again, as we've been talking about guidelines, it takes a little while for new products and new treatment approaches to be written into the guidelines and, taken up by clinicians who are practicing in that area. Specifically as it relates to EoE, and we think about how the clinical trials were, designed. Dr. Reiter, in the case where we have something like EoE that has newer drugs that, potentially show higher efficacy, how are y'all addressing those in clinical guideline development?
Yeah, no, that's a good question. I think this is oftentimes a challenge we face a lot in managed care. You know, it's almost like the drugs sometimes can get approved faster than guidelines can get developed, depending on the cadence with which those get updated. You know, I do think there are a variety of ways that we try to make sure we're staying ahead of the curve. One I mentioned earlier, I think the FDA labeling for drugs and for new drugs that get approved, including the studies that are used during approval, are typically leveraged as something that is reviewed when building a formulary and when reviewing new approvals. So I think that that's one way. I think another way, you know, most organizations that have a pharmacy and therapeutics committee, P&T committee, you know, they often try to incorporate specialists into that committee, whether it's somebody who has direct experience managing EoE or is an expert in that field and maybe has a, you know, network that they tap into. And if not directly through a P&T committee, you know, I have seen several ways where a P&T committee at a payer organization will reach out to experts in the field when there is that gap internally and kind of talk through, you know, this is a new approval. We're recognizing what the guidelines say, trying to get a better sense for how are these being used in the real world. How is this evidence comparing to what's in the guidelines? And if, you know, there's any, I guess, sense of how guidelines might evolve based on new approvals and things like that. So I think those are some of the key ways. You know, there are other things too, I think, especially for maybe integrated systems where you have the provider groups that are providing care as well as the payer kind of under the same umbrella. Oftentimes there might be shared committees, whether it's a clinical focus committee, economic evaluation committee, something like that, where I think a lot of that communication and data sharing occurs, or maybe there's even more specific data sharing. So when particular drugs are approved, you know, maybe there are this concept of not necessarily gold carding, but almost like if you have a specialist who's at a center of excellence who is maybe, you know, able to have a little bit more independent authority in prescribing. And then maybe that, you know, that data is being transmitted back to the payer and kind of offering almost like an internal route of real world evidence collection and evaluation. And I think those are all just some ways that immediately jump out to me in terms of how, you know, those are or how payers work to try and stay ahead of those when new approvals are coming on.
Dr. Dellon, you mentioned new tools relating to identifying disease severity. And I know one of the things that oftentimes happen through clinical trial design and even when guidelines are developed, there often is not necessarily a clear definition of disease severity and also not necessarily a clear definition on response to therapy as well. But you had mentioned that there is a new tool that potentially is being developed to define severity. Could you talk about that just a little bit?
Yeah, absolutely. So it's called the Index of Severity for EoE or IC. And the idea was the group of us who developed it really were modeling it off of the way that severity is measured in asthma with some of the, you know, the GINA guidelines and related, where there's very clear definitions. And more than that, those definitions have clinical implications with what treatments you use and how frequently you see patients. Now, those types of guidelines are, you know, they're very mature, 20, 30 years of experience and data. And this is brand new. It was only published a year and a half ago or so. But what this is for EoE is we look across 3 different domains to define severity. One is symptoms and complications. The second is the inflammatory feature. And the third is the fibrostenotic features. And so, you know, symptoms is primarily how frequent the symptoms are, how much they impact people. Complications can be things like arriving at an emergency room with a food impaction or having an esophageal perforation or having malnutrition because of EoE. You know, on the inflammatory side, we're looking at findings in the esophagus and on the biopsies, and same thing with the fibrostenotic area. And so you can do a quick score. There's actually an app that the American Gastroenterological Association has made for clinical practice. If you have all the data, it just takes, you know, less than 30 seconds. And you can get a severity, whether it's inactive, mild, moderate, or severe. Now, so far, we've essentially been able to validate that the severity index does reflect clinical severity. It tracks with a number of features that aren't even included in there. We show that severity can improve with successful treatment. We know generally the distribution, so maybe 10 to 15% of the population is severe, 40-ish mild and the rest moderate, depending, of course, on what populations you look at. And it's only just recently at one of our meetings this past spring that some data came out that showed the patients who are classified as severe have less response, perhaps, to some treatments. And actually, the response decreased in stepwise fashion from mild to moderate to severe. So that is very helpful to start thinking about how we might suggest treatments based on that. And so I think what a lot of people hope is if someone is severe, maybe you use more of an inflammatory bowel disease model where you start, top down with the most potent therapies rather than step up. We're still quite a ways away from that. Obviously, that's supported in IBD with very large, rigorous clinical trials, and this is just at the beginning point. But interestingly, at least for the 2 drugs that are approved so far, they are approved with a label that doesn't have any caveat related to disease severity. And that's in distinct contrast to, say, asthma or eczema or even IBD. And so even though I think everybody wants to be good shepherds and use maybe the more expensive therapies in those more severe patients or people who are refractory, from the FDA labels, that isn't a requirement. But anyway, I think ultimately this severity index is going to be helpful to try to guide therapy a little bit.
Thanks, Dr. Dellon. Tell me a little bit about, from your perspective, the primary barriers to treatment for EoE that patients face and also that treating clinicians face.
For patients, there are barriers that are related to actually accessing care and the specialists who take care of the condition. There's actually not that many people who fully specialize just in this area. And so, I think to, what Dr. Reiter's point was before, that a lot of people may not actually be familiar with the most up-to-date treatments and the most up-to-date guidelines as to what to do. And in particular, generally this is a condition that is treated by specialists, gastroenterologists, or allergists in general, and not in the primary care domain. So I think for patients, finding those and then finding those providers, and then of course accessing the treatments and the cost of the treatments and the cost of monitoring is with endoscopy, are quite high. And so, with patients needing to have good insurance with good coverage. And then even then, I think another barrier that the patients face and the providers as well is the insurance coverage. So even like this newest budesonide oral suspension, it was approved this year, but it isn't on a single formulary yet because it's too new. And so every single prescription is denied. And then, so every single prescription for what should be a first-line therapy requires 2, if not 3 steps to get it approved. And I know that gets better over time, but that's certainly a barrier for patients. And then for physicians, I think not everybody has the resources to, take those appeals forward, and they may just revert to less effective therapies or try different therapies. And so I think those are barriers for the providers as well.
Dr. Reiter, so thinking about some of Dr. Dellon's comments, and then just thinking about it from the payer perspective, how can payers address some of the barriers to care and help improve appropriate access for patients to effective care?
Yeah, it's a very good question. And I think Dr. Dellon raised a lot of important points. On one hand, I think there's the insurance coverage piece that was mentioned, and that is a challenge, I think, because there are a lot of payer organizations that have very scheduled P&T committee reviews for different therapies or drug classes. And so, as Dr. Dellon mentioned, if there are newly approved therapies that come out, depending on timing, it could be 6 months or more in between that time of approval and before a payer evaluates that for coverage, which, as Dr. Dellon outlined, can lead to a lot of providers not necessarily pursuing an appeal, and therefore members aren't receiving optimal care. So, I think there are small ways. These may be a little bit more specific examples, but, thinking about a payer process and understanding if there are disease states like EoE where, almost having some way of tracking if, there are new therapies that come approved, and kind of reinventing a process for how can we look at those potentially more quickly to make sure that members are getting that care, or if there are providers who are specialized in treating this, I know that doesn't necessarily solve all the access issues, but thinking about, is there some sort of interim pilot, type program where those providers have a little bit more freedom and flexibility to prescribe those newly approved therapies, and then plans can then collect that data, which I think benefits all parties involved and obviously gives members potentially faster access to those. Those are just, I think, a few ways on the insurance coverage piece specifically. And then, I hear Dr. Dellon talking as well. And from what I've learned about EoE, it is a highly involved disease state in terms of the number of providers that you need. I hadn't really even thought as much about the procedure part that Dr. Dellon mentioned in terms of having to go in and potentially do an endoscopy on more than a single occasion to monitor progress, because that is one of the ingredients for monitoring severity. So almost the, medical home concept, if you will, which I know a lot of payer organizations talk about. I haven't necessarily seen that be executed as successfully, but almost like a medical home for GI or for EoE. And thinking about, from where I sit in my role as someone who helps develop clinical programs, as the payer that sits kind of in the background of the entire system and has some sort of connection to providers, some connection obviously to members, and then all others involved in care, whereas one type of provider might not have as much direct access to another. What steps can payers take? Is there some sort of data infrastructure that could be built? Is there some sort of value-based arrangement that can be designed that includes all? Can there be some sort of program that's internally driven by the health plan where it involves all of the providers that are needed, whether it's a gastroenterologist, whether it's somebody providing behavioral or mental health care, all these other specialties and subspecialties that might be needed? Those are just some things that really jump out to me as some ways, that payers can support eliminating some of those barriers to access.
Dr. Dellon, you mentioned in your comments about access to specialists, which we know is problematic, not just for gastroenterologists and allergists, but other specialties as well. Can you tell us a little bit about how you see telehealth as potentially helping serve the need to fill that gap into access?
Yeah, I think telehealth is incredibly promising for EoE, and EoE may be a perfect disease actually for telehealth. It's a condition where you spend a lot of time on the clinical side talking to patients and getting their opinions and views and doing shared decision making, as opposed to detailed physical exams. And so I think having telehealth, not only it expands the reach, which gets you to be able to see patients in a location where they don't have access to a specialist or an expert center, but it also allows you to be more patient friendly and save time. And you can do a 15-minute follow-up visit in 15 minutes without having a patient drive 4 hours back and forth, even if they can do that. And so that lets that patient stay at work the whole day instead of taking a whole day off. And it's much more efficient, I think, for everybody. And so for me, actually, a lot of my practice is phone follow-up and some telehealth follow-up, and mostly seeing patients in endoscopy when the active aspects of their management are being done, and then saving those clinic visits for new patients, for patients who are following up after being stable for a long time, and that sort of thing. There's one study that was presented as an abstract a couple of years ago showing it was a study of EoE and EGID patients, and they were very pleased with their telehealth experiences and didn't really see much of a downgrade with in-person care for a lot of it. So I think it's very acceptable to patients as well.
This question I'll ask Dr. Reiter you to answer, and then Dr. Dellon, I'll ask you to chime in as well. But is there a role for supporting patient education in decreasing some of the access to care issues that happen as well? And Dr. Reiter, are there opportunities for payers, managed care organizations to get involved with patient education and support? And then Dr. Dellon, if you could talk to it from the physician-clinician treatment perspective as well. But Dr. Reiter, if you wouldn't mind.
Absolutely. And I'll just say too, real briefly, I think the area of telehealth is an area that payers are very interested and engaged in as well. Again, it's one of those that, in terms of the cohesion between telehealth and the rest of providing care, I don't think as payers we always do the best job of that. Now, granted, I do think, with the pandemic, telehealth has gone up quite a bit. So I think that a lot of that will improve over time. And then in terms of the question about education, I think absolutely yes. And I think that this is an area that payers have a lot of opportunity in. I think the way that it's viewed really from a lot of stakeholders is the burden of education is on providers. And obviously, as providers are becoming more and more stretched with their time, we read about all the time the shortage of providers and the burden of disease that's been growing. And Dr. Dellon talked about the incidence or prevalence of EoE is increasing pretty dramatically, it sounds like. So, they're stretched for their time. They're dealing with challenges. And I think health plans can really play a critical role in this. And, not to call out any one payer, but as a patient myself who, has been with different health plans for my own healthcare coverage, I've never really gone in and been overly impressed with the amount of educational information that's available just on the payer website, because that's, I think, an example of a place where patients commonly go to view what are their charges, what are their benefits, and, what's their network look like. And a lot of times, even the basic network information isn't always easy to navigate. So I think, by way of an example, I think payers have a big opportunity there. Is there something that you can do to not only provide obviously up-to-date network information, but also are there any other programs that you can participate in as a health plan member? Are you partnered with a vendor? Are there telehealth options? What does your drug coverage look like? All of this stuff is supposed to be incorporated into a lot of health plan websites, but almost consolidating this in a single area within a website. And also, I think bolstering the amount of background information just in general on the disease state. Dr. Dellon talked a lot about how these are treated in real life. I know I've learned some things about the app that's available for disease severity, the combination versus singular therapy, and what the evidence says versus how often it's actually utilized. I think just little things like that, there's some big opportunity. But there's also other, methods of communicating and educating as well, whether it's direct patient outreach, whether it's partnering with providers to understand who are these members, and then using our connectedness with those members to push out educational materials, or, as somebody who helps develop clinical programs, whether it's an internal clinical program, such as care management that we have going on, if we have clinical pharmacy programs where we're maybe doing outreach for one thing, is there a way to, incorporate education or talking points, or even just baseline assessments for things like this into those types of programs? I think those are all ways that we can, improve our education materials. And I think there's a big role for payers to play in that space.
Dr. Dellon.
Yeah, I think it's a really interesting concept, and I think it could be very useful because there is a limited amount of time for education in the office in most practices. And I know that patients often will try to do, get their own education online, but it's, not very curated. There are a number of good resources for patients already. A number of the GI societies like American Gastroenterological Association, American College of Gastro, they have patient-focused materials that are developed specifically for patients. There's also a number of advocacy groups. Two of the largest ones are the Cured Foundation and the American Partnership for Eosinophilic Disorders, and they have information as well. But I think a model where, a plan will know because they have an EoE billing code or an EoE medication on file, that then they could, reach directly to the patient to say, do you want to go through some of the educational resources? I think that would add a very nice and potentially complementary approach to what else is available.
Thanks for that. So, Dr. Reiter, Dr. Dellon mentioned a little bit earlier when he was talking about just some of the barriers, for patients. Two that came up were like, access to the medication due to insurance coverage requirements and affordability. So are there some things that payers could actually do to help address and provide appropriate access, and then also kind of focus on the affordability of treatments for EoE?
Yes, absolutely. I think there are things that payers are doing or typically do to address both. A lot of them, I think, are specific to the drugs that are used to treat EoE and other diseases. But I think in terms of the piece around access, I do think there is work that is done just on enhancing provider networks in general. and also the expansion of telehealth, which are things that were mentioned. But in terms of some other maybe more specific examples, I know there are different formulary and contracting strategies that a lot of payers use. So for example, maybe a tiered formulary that offers a preferred agent. Usually by placing certain therapies in a preferred status, it allows for prioritization of most cost-effective medications, which obviously allows payers to then, keep rates down for those that are on a lower tier. So specific to EoE, this may include some of those corticosteroids, and proton pump inhibitors that are maybe considered, more first option. Typically, I know there's a newly approved therapy that's branded, but if there are more generic options available for those as well, a lot of times those help address the affordability issue, particularly if patients haven't tried therapy in the past. And obviously, to kind of tie it back into the guideline discussion earlier, typically the longer a therapy has been out, the more readily incorporated into guidelines they are. And so that's just another, I think, bonus to that as well. Another interesting thing, I do think there's some work that's being done around value-based arrangements for pharmaceuticals. Typically, those are done with the more expensive, like biologic medications. That is, still in the earlier stages overall than some of the tiered formulary stuff that's been around for a while. But I do think, when you have that evidence base that's available for maybe those therapies that are maybe considered first line or have been around longer, it provides more opportunity to potentially negotiate a value-based arrangement, which can help, again, improve the access, but also drive down or improve some of the affordability. A couple other things, I think prior authorization criteria that's aligned with guidelines. Some payers have streamlined their prior authorization processes by aligning their criteria with the clinical guidelines, so that, just ensures that patients can receive the most appropriate therapies quickly. So I think that's one thing on the access side, and then lastly, again, this maybe goes to some of the more expensive biologic medications, but you also see it with some of the generics or those that have been out. But if they're used across multiple therapeutic categories, sometimes the contracting strategy might be, if I have 3 or 4 different disease states that this drug can be utilized in, what can we do to offer, more of a preferred status across all, so that, you get that higher volume, which typically helps bring your rates down and also might help drive further rebates as well. So I think those are some things that payers might look at. Obviously, each payer has their own unique strategy. I think most, if not all, try and ensure that the most clinically effective therapies are utilized, but that is one strategy that I've seen play out as well.
Thanks, Dr. Reiter.
Yeah, and let me just jump in real quick about just one of the points that you made. I just wonder to what extent that some of the clinicians are involved, because I think I understand, and this is very EoE specific, the goal of, maybe if there's an equivalent generic kind of using that. But I think for EoE, particularly with, say, the budesonide products that are approved for EoE, they are, manifestly different from the other budesonides out there that are generic, where patients actually have to mix their own syrup, and it's impacts adherence and probably efficacy as well. So I think some of those things are, maybe well addressed with sort of a back and forth between all of the stakeholders there.
No, absolutely. Dr. Dellon, so thinking about a patient that has EoE and the multiple physicians and professionals that are involved in the care of that patient, what are the opportunities for multidisciplinary teams to contribute to the effective management of a patient with EoE?
Not every patient with EoE needs a multidisciplinary team, but it is a multidisciplinary condition, and a lot of patients benefit from that. And so, often allergists and gastroenterologists are involved in the care. Other members of the team may be dietitians or nutritionists. Certainly pathologists are involved when looking at the endoscopic biopsies. And sometimes psychologists and pediatric feeding therapists as well. And there are, I think the ideal is to have a multidisciplinary clinic in one location under one roof, but that's really aspirational. And there's only a few places around the country that have that. For example, even with the work that we do at UNC, we don't have that type of a clinic. And instead, we have different providers who see the patients, but in their own clinics, and then we coordinate outside of those specific clinic visits. So I think for patients who have that need, I think their care can really be streamlined, and many aspects of their conditions can kind of be managed together.
Thanks. Dr. Reiter, from a payer perspective, how can payers support multidisciplinary approaches and support and identify gaps that may exist for patients who are being treated?
Yeah, that's another good question. And similar to the education piece, I think that payers have an important role to play in sort of helping to build and support that multidisciplinary care model. And I think there are several ways that they can and do that. First, I mentioned, sort of the patient-centered medical home or EoE medical home type model. I think looking to do whatever they can to build that, whether it's enhancing current network, whether it's helping to build an internal program, or stitch together a variety of different programs, whether it's working with a local provider group, maybe it's working with Center of Excellence, maybe a payer already has a unique vendor partnership or digital platform that they're utilizing, but just sort of stitching those together to help create that sort of model as best they can, if you can't do it in its purest form, is one way. I think, a few other things that could be considered. Obviously, Dr. Dellon talked about some of the back and forth with the budesonide, and we've talked a little bit about guidelines and P&T. And I think that, as I mentioned, a lot of payers do try to incorporate specialists, but I would imagine that EoE is a gap for many. And when you think about the day-to-day operations of a payer organization, there's P&T, but there are also medical policy development and everything else. And I think one strategy is, a lot of times there are physicians, mid-level providers, pharmacists on staff at a payer organization, thinking more broadly about what type of expertise, can you bring into the organization to kind of generate sort of a mindset shift in just overall thinking and program development is maybe one way. But then also, looking at internal processes and clinical programs that support multidisciplinary care. So most payers have a care management program, but I think that those vary widely. I've seen some payers that use those for maybe just somebody who's on a high cost drug that's above X dollars. I've seen some that focus on a specific disease state, and I've seen some that are focused on, quality, attached to quality programs with CMS, and some that are just broad. And so I think like tailoring those and designing those that are more specific, again, could be attached to that GI medical home, EoE medical home type model or not. But just, again, utilizing what resources you have, partnering with the providers that you have relationships with to try and build those tailored programs as best as possible is probably the overall best thing, at least from where I sit today, that payers could do to support that.
Yeah, and the medical home is interesting because, this is obviously an entire focus on the pharmacy aspect, but another huge driver of costs for EoE are the endoscopies. And I know that's in a different division of the insurance, but if you're looking at costs from a global standpoint, it's quite possible that some of the more expensive medications lead to less endoscopy utilization down the road if patients are doing well. And that is, we haven't really talked about that at all, but that's, I think, an important thing to be considered globally if there's discussion internally between those two, paying, which I know is separate, but it's important.
I completely agree. And, I mentioned briefly the difference sometimes between there's the P&T committee and there's medical policy. And a lot of times those are siloed at payer organizations. And so figuring out a way to bring those together, because you're absolutely right. And then I think too, another thing, investing in the data infrastructure to actually track that, because a lot of times a member, I guess, may go to various providers, and each provider is probably keeping track of when the last endoscopy occurred. Maybe they only have one provider that's doing that if they're consistently seeing the same person. But I think health plans can play an important role in helping to, either work with partners to ensure that everyone has the information on patients' care, building some sort of internal dashboard that houses all that data that providers can access, log information into real time, or just figuring out how to partner with providers for what's the best way to communicate that information and vice versa. I think it's really important.
All right. Well, Dr. Reiter and Dr. Dellon, I just want to thank you so much for joining the discussion today. Thank you for your insights.